Swayam Prabha. Digital India. Educated India.
Welcome friends once again to our NPTEL MOOC module on health economics. This is our week number 7 or unit number 7. We have been discussing the aspects related to economics of health system. This is indeed our last lecture in this week. It's on understanding health system around the world. We have discussed different type of health system and its features, criteria, etc. Now we will discuss about the evolution of different health system and their status. Of course, this is the perspective from the world and experience of the different countries in terms of equity will also be emphasized. Now, it has a genesis connecting to the different time paths where the health system is actually conceptualized. We refer to the period 1980s, especially the late 1980s, where especially before that period, it is largely dominated by tax based system or even social health based systems, health insurance based system. But presently we will be or we are actually going by a system which is characterized by a mix of private and public. So it has there are sub components as well. And we will be emphasizing and discussing, started discussing with different characteristics of the present health system in our previous lecture as well. But we will be now discussing on what was the different evidences of health system from especially from 1980s onwards. So there are major changes occurred. We are referring to the the end of 1980s. And this has involved innovations in mixing public and private roles in health system. So in short, 80s onwards, referring public plus private health systems. So now here we have different historical profiles of the period 80s onwards. So in the mid 80s, health system was largely characterized as public private spectrum. At the purely public, we refer to the concept introduced in their time is called Simaxo system. So where it is purely public. So this is actually referred to the former communist countries of Central and Eastern Europe. And in this system, we usually have centrally and publicly financed structure. And so that means all services are free of charge. So we are actually referring the countries such as former German, Democratic Republic and Uganda, where Simaxo system was largely practiced. In contrast to this, what about private and VHI, voluntary health insurance? That means there are limited number of countries which also adopted this private and VHI based methods. This has coexistence with the form of cover or compulsory arrangements. US was the first and most prominent country that relied on this set of arrangements. Okay, so we need to explain in practice Simaxo system, divergence system divergence reported and substantial on under the counter payments seem to have been made by patients to secure services. That is a form of default privatization. So though we have been saying that Simaxo system is purely public based, but there are some reports with little diversion. Even in practice of Simaxo system, we find some to secure services through the under the counter payments, and that's called a form of default privatization. So there are other case studies we will be referring as experiences of different countries. We start with UK health system, then we will also discuss Federal Republic of Germany, its health system, and we'll also emphasize Latin American countries and their health systems. Start by UK health system. It is largely publicly provided and financed national health service, which we discussed in our previous lecture as well. This included some user charges, such as in the case of dental and optical services and for prescriptions. Small private insurance sector outside the NHS scheme, that is National Income Scheme, was also there in UK. Most resources are owned and employed publicly, but primarily for the primary care doctors, they have since 1948, and so that means the most resources are owned or publicly owned, but primary care doctors have since 1948 been contracted private individuals or firms. Okay, and especially this period is noted to deal with the primary care doctors, and there are some examples noted. They are like Denmark, Sweden, and New Zealand. You can read the paper of OECD 1992 and 94 to verify these discussions. So they have the health system called largely called Bevanite health system. Uh, so this is named after the person called Anirin, Bevan. Another case study is from Federal Republic of Germany. That model is largely called Bismarck model of social insurance. We also discussed in our earlier lectures, and introduced in Germany. 75% of the population was insured compulsorily. Then that is roughly around 13% voluntarily with the same sickness bonds, and 10% of the population was insured privately. So 13% those voluntary are also called quasi public insured persons. Both public and private providers account for 51% of the hospital beds, where 51% of the hospital beds were public. Ambulatory care physicians and pharmacies were largely private. So need to note it very clearly. Even if it is public based dealings, still some of the categories called ambulatory physicians and pharmacies are under private financing. Belgium, they've adopted the co-payment structures, which we discussed earlier, and which is more substantial and a higher proportion, and largely that is tax-based finance. France, it is of 99% insurance with statutory sickness bonds, but a reimbursement model for many health sector transaction, whereby health service users paid and were later also reimbursed. In case of Netherlands and Austria, you will also find this structure, and you can also the same structure, you will you can follow from the OECD paper of 92 and 94. Coming to the last case study in this section is on Latin American countries. They used to have a parallel system. What are they? That's called three subsystems: public, social insurance, and private. So it has implications on I mean basically implication in terms of insurance and out of pocket financed structure. We are referring to Mexico and the countries of Central and South America, excluding the Caribbean island nations. This covers different segments of the population in terms of the coverage. Okay. Now we are counting the transition period to the recent period. We refer to the period transition period of 80s because lots of discussion started on this aspect of health systems, emphasizing the payment structure. So after mid 90s, series of innovation in health system design started. The Simaxo system, which we already mentioned, has a transition to the market oriented system. So the transition is from Simaxo to market oriented, where largely it is private based. Bismarck model of social insurance, and it has also transitioned to varying degree of success in different time period. And Bismarck model we already discussed. However, Czech Republic adopted a social insurance model in 1991, and with several insurers financing healthcare providers based on contracts. So you can prepare your objective questions in these directions, like we may ask you the cases is of which kind of model. Okay. We have discussed so far Simaxo, market oriented, Bismarck, Bevanite system, etc. So we are again unfolding the discussion of Bevanite system. This introduce contracts between public purchasers and public providers of the services. That is all about role of private investment funding in the public functioning as well. So that's about called Bevanite system. For example, UK responsibility for purchasing services was separated from responsibility of providing them in 1991. They starting with the earlier system, then there have been a transition. So poorer countries modeled on Simaxo or Bevanite systems introduce reforms to improve the performance of the public sector and to better regulate the private sector. New forms of partnership arises in the transition basically between public and private sector, and example we have already cited. However, we can discuss this like partnership in pharmaceutical and vaccine distribution, technology diffusion, and in seeking to extend the availability of HIV and AIDS related treatments. These reforms have not changed the plural nature of these health systems. In some respect, may have increased their diversity. Referring to the Bismarckian health system, introduced the greater roles of public regulation, and in some cases provision, but also new and larger co-payments arises. Several Latin American countries sought to achieve greater universality in terms of distribution and to lower the boundaries between segments of their systems. Brazil, for example, Brazil introduced the unified health system, that is called SUS, in 1988, and Colombia started to integrate its public and social insurance system through reforms which came into effect in 1996. Here are some of the patterns based on different models, experiences of the different countries. We are referring to earlier paper or work. So it is related to originally Bevanite system, then Bismarckian system, and then private insurance format. Different countries are actually referred. You can have a check. This is Bevanite, Vixian, and private insurance based formulation. You can easily see their total health expenditure from different period. You are referring to the transition period. You can just have a check. So between 1975 and 1995, Bevanite system had lower levels of per capita expenditure. You can just have a check. So per capita expenditure is mentioned in this column, and we are referring to 75 till 95 period. And so you can just have a check of this period in terms of per capita expenditure, total health expenditure, and percentage in health expenditure. And then we will also refer here from the table. You will also find out high proportion of private voluntary insurance, the US and Switzerland. Okay, here the private voluntary insurance is of high percentage. Especially we are referring to these private insurance cases, and in number of cases it is very high. The gap continued to narrow between Bevanite and Vixian systems, and you can just see this difference over these compared to these, even these as compared to these, there are changes. Even in later periods also there have been cross comparison possible. The gap continued to narrow between Bevanite and Vixian system up to 2015, while broadening again between both of these and those that originally were private insurance, despite Switzerland's movement towards Bismarckian principle. Okay, it is noteworthy. So even if that occurs, still you will see the gap continue to narrow between this Bevanite and Bismarckian system. Now we are emphasizing on performance in terms of equity, though we have a dedicated chapter to clarify the principles of equity in healthcare. However, equity really matters in terms of healthcare, better healthcare system. We have we have already discussed about performance in terms of equity and the related terms such as Lorentz curve, concentration indices, and others in unit number 4. We will be discussing the different experience in terms of equity. In Sweden, where it was not possible to separate GP and specialist doctors utilization, and the pattern accorded with that for specialist, that is inequitably in favor of high income groups, and this was the case for total physician utilization across most countries. You just make a note that you can also refer to our appendix. We have given all the details to especially to get the overview of healthcare system of 10 developed countries from economics of health reconsidered by Thomas Reich. That is with the title Health Administration, with the press called Health Administration Press, Chicago. Page number is also mentioned for your reference. Now we are emphasizing on inequality and inequity in utilization. We are referring to OECD countries, and we are also clarifying through the CI, that is concentration index and horizontal inequity index of Dorseler and Masseria 2004 paper. So, and here you can see this is the comparison given by different income quintile, especially poorest to richest, and their confidence interval is given. Again, the check is through Bismarckian system and Bevanite system and private health insurance. Analysis especially by Devux and Loop in 2012 discussed this aspect as well, concluded with few exceptions, that is patterns of inequity in GP and specialist utilization have remained relatively stable between the period 2000 to 2009. The REITs tends to favor insurance policies with high deductibles, and this may explain their using less health insurance and contribute to poor pro for inequity that was emphasized and observed by Dorsler and Messeria 2004 paper. Analysis by Bago Yuva et al. In 2009, they emphasize about alternative methods to those by Dorsler and Messeria or using the European data, which includes Belgium, Denmark, and the Netherlands. They found similar patterns of pro-poor inequity in GP utilization and pro-rich inequity in specialist visits for these countries. For low and middle income countries where different types of health service utilization are most relevant. Okay. Now we are actually referring to that low and LMICs, low and medium income countries. As you know, this is usually referred to the World Bank data, and emphasis here is on inequity in utilization. Then again modeled through Bevanite or Simaxu based, then through segmented based private and public segmentations, and even Simaxu based is mentioned with their country's relevance. So just have a check that almost all the indices are positive and many of these are statistically significant. This indicates pro-rich inequity generally applies across the group of countries for the services. There are some exceptions. Exceptions are pro-poor inequities observed in Kenya, Uganda, and Kyrgyz Republic in the proportion of children with diarrhea given appropriate treatment. So this is what is mentioned. However, the exceptions are pro-poor inequities, which is just mentioned in the context of Kenya, Uganda, and the Kyrgyz Republic. And poor pro inequality is also observed in Bolivia in the proportion of children aged 12 to 23 months who receive BCG, measles, and 3 doses of polio and DPT. On average, this group of countries has higher levels of inequity than the segmented health system of Latin America, which in turn have higher levels of inequity than the Simaxu health systems, with the exceptions of the pro-poor patterns for treatment of diarrhea and acute respiratory infection noted for Kenya and Uganda in particular. So, since this is our last lecture, we are here to summarize the entire 5 lectures. Here we discuss about the differences between private health insurance, social health insurance, and even tax-based health systems. And we know that we clarified what happens to the impact of all these on out-of-pocket spending or their health spending. In some cases, when we say private, we refer to voluntary payments, where in social we are usually refer to Simaxu system, and also we refer to the insurance which is taken up by the public institutions or largely by government. And in some cases, we discuss about the co-payments based, and we also model the discussion through the effective implications of each of the insurance schemes. And it is observed that at the point of implications or the point of access, and if the payment is made, moral hazard is considered to be lesser. Okay. And so far as private health insurance is concerned, we refer to the countries predominantly with this PHI is in USA, whereas in social health insurance, the European countries, mostly by France, Germany, Luxembourg, and Netherlands, whereas tax-based financing healthcare was in Denmark, Finland, Ireland, Italy, Norway, Portugal, Spain, Sweden, and UK. And there are different dealing with moral hazard issues, which I already mentioned. It is based on co-insurance or deductible based or no claim bonuses, etc., where there will be considerably low level of moral hazard, while in other cases you will find higher amount of moral hazard. So, different health insurance is the categorization based on financing mechanism, as already mentioned, tax based social health insurance and private health cases. In short, rationing methods to the highest priority applications for maximizing social welfare, such as gatekeeping, setting supply of services, waiting lists, queues, and others are already discussed. Now, other two important point to summarize as well. We have discussed, however, we discuss about these rationing issues. Rationing is through price competition or the non-price competition. Largely, price competition itself is considered to be a high degree of rationing method. So, even we discuss about retrospective reimbursement in different structure, or compulsory insurance in which payments are related to ability to pay. So, anyway, we have all discussed. If you follow these lectures, I am sure you can able to get it. Experience of different countries on the basis of equity, healthcare expenditure and others are discussed. To follow the content and understanding, we will refer once again for this. Here is our reading of the latest book 2020, and it's on health economics, published by Routledge. And what are there in our next unit? We will be discussing on theory and principles of economic evaluation, foundation of economic evaluation, and decision rules for different approaches. With this, it's my privilege to close the lecture, and we'll look forward to the next content. Thank you.